Primero que nada, no podemos dejar de alzar la voz con la situación que está ocurriendo en Gaza. Como pediatras, como neonatólogos, creemos en la Declaración Universal de los Derechos Humanos, que establece que todos los seres humanos nacen libres e iguales en dignidad y derechos, y dotados como están de razón y conciencia, deben de comportarse fraternalmente los unos con los otros. Asesinar a niños inocentes y usar la inanición como elemento de guerra son actos criminales. Y utilizo esta frase que pone mucho la doctora Granados en sus presentaciones de Gabriela Mistral: muchas de las cosas que nosotros necesitamos pueden esperar. Los niños no pueden. Ahora es el momento. Sus huesos están en formación, su sangre también lo está, y sus sentidos se están desarrollando. A él nosotros no podemos contestarle mañana. Su nombre es hoy. Aclarando también las situaciones de aval y puntaje, para las sesiones, se les recuerda que nosotros lo solicitamos a la Federación y al Consejo Mexicano de Certificación en Pediatría, sección de neonatología, y se hace por trimestres. Los requisitos para obtener la constancia del trimestre es la asistencia a través de Zoom, cumplir con una asistencia mínimo del 80% en cada sesión y haber asistido de manera virtual al menos 2 de las 3 sesiones de cada trimestre. Se dio el taller de reanimación neonatal para instructores de manera exitosa. Y bueno, vamos a continuar con esta actividad liderada por la doctora Marta Granados. También en conjunto con el Instituto Nacional de Perinatología se va a hacer una serie de cursos donde se habla de diferentes técnicas de monitorización, incluido el ultrasonido, y con mucho éxito se dio el curso de neuromonitorización, donde hablamos de diferentes técnicas, incluido el ultrasonido transfontanelar, el ultrasonido, la neurosonografía fetal, el NIRS y la electroencefalografía de amplitud integrada, y tuvimos el gran gusto de que nos acompañara el doctor Juan Arnaez. El siguiente curso va a ser de focus cardíaco y va a ser en mayo 23 y 24. Estaremos poniendo la información en las redes. Y como les decía, tuvimos el gran gusto de tener con nosotros al doctor Juan Arnaez. Fue muy enriquecedora compartir y revisar casos juntos. Y recordamos que la asociación tiene un acuerdo de colaboración con la Fundación de Neurología Neonatal. Entonces, hay un descuento especial para los asociados. Nada más necesitan enseñar que son asociados de la Ciudad y Valle de México, y hay descuentos especiales en los cursos. Y algo que fue muy emotivo y muy significativo para nosotros fue poder homenajear a la doctora Mari Segura Roldán. Ella, pues, es, como todos saben, de las grandes pioneras en neonatología, pionera en muchas cosas, la primera mujer en ser presidenta de nuestra querida asociación y también de ser presidenta del Consejo Mexicano de Certificación en Pediatría, sección neonatología, y pues es la que trajo el ultrasonido transfontanelar a las unidades de cuidados intensivos en México. Entonces fue un honor tenerla, doctora, la queremos mucho y reconocemos que estamos sobre los hombros de gigantes y toda la contribución que ha tenido en la neonatología mexicana. También se dio el curso de ultrasonido pulmonar en el Congreso Triestatal de Neonatología, muy contentos de regresar a dar talleres, incluyendo la sesión práctica en las unidades de cuidados intensivos e intermedios, muy agradecidos, y la pasamos muy bien, y se capacitaron a más de 33 neonatólogos. También les recomendamos el podcast de La Incubadora, donde nuestra amiga Caro Michelle es una de las presentadoras, la versión latina de Incubator, que es un podcast muy exitoso. Lo pueden encontrar en todos los sitios donde se transmiten podcasts. Y es para mí un honor iniciar la sesión del día de hoy con el doctor Yasser El Sayed. El doctor El Sayed, MD, PhD, es profesor de pediatría de la Universidad de Manitoba. Él se formó en Egipto y posteriormente emigró a Canadá, y actualmente es uno de los neonatólogos con mayor influencia y que ha publicado de los artículos más importantes. Su principal fuerte es la incorporación del ultrasonido, pero también el concepto del abordaje integral del paciente basado en fisiopatología, que es algo crucial para los que hacen terapia intensiva neonatal. Todos conocen su sitio Pocus Neo, que ahora es el Neopets Academy, donde se conjuntan más de 8,000 profesionales de la salud en más de 126 países. El doctor Yasser ha impartido más de 100 talleres en los últimos 7 años y también es autor de más de 100 artículos, capítulos de libro y abstracts. Entonces comenzamos la sesión. Y vamos a hablar un poquito de la experiencia nacional que hemos tenido en la introducción del ultrasonido abdominal, específicamente en la sospecha de enterocolitis necrosante. Estas imágenes son de el 2012 del Manual de Pediatría del Hospital Infantil de México, más o menos cuando yo terminé mi formación como residente de neonatología, y muestra cómo las dos herramientas principales que tenemos para diagnosticar enterocolitis en la placa de abdomen es la neumatosis ya sea gástrica o intestinal y la neumatosis porta. Y como todos sabemos puede ser difícil, puede haber variaciones entre los observadores de la placa y muchas veces quedamos con dudas acerca de si existe o no, y justamente la presencia de neumatosis intestinal es lo que confirma la presencia de enterocolitis necrosante. Una proyección lateral donde también podemos ver imágenes de neumatosis intestinal. Y también en el manual incluimos que el neonatólogo podía pedir ayuda del radiólogo para buscar neumatosis porta, que era mucho más rápidamente evidenciada por ultrasonido. Posteriormente, pues ha venido toda la explosión del point of care en la unidad de cuidados intensivos neonatales y aquí les presento la versión revisada del SAFE de la doctora Nadia Youssef, donde agregan la búsqueda de líquido abdominal libre. Entonces es importante porque son imágenes sencillas de tomar que se pueden tomar rápidamente en aquel neonato que se descompensa y nos pueden dar mucha información. Yo aquí creo que también se podría agregar la presencia de neumatosis porta. Entonces aquí vemos un ejemplo de cómo una sonda lineal, es una sonda lineal portátil de bajo costo, puede ser extremadamente útil cuando tenemos un paciente ya sea con abdomen o con pulmón blanco. Este es un neonato de 33 semanas de gestación, 43 corregidas, tuvo SDR, síndrome colestásico, ya había tenido múltiples procesos abdominales y pues tenía un proceso abdominal en estudio. Y como pueden ver, pues identificamos rápidamente que hay líquido libre. El líquido libre es complejo, tiene ecos en su interior y podemos ver las asas intestinales congeladas. Igual del lado izquierdo, podemos ver la presencia de líquido libre y podemos identificar las asas intestinales. Entonces, gracias a este algoritmo clínico que se publica en el 2022 y a todo el trabajo que ha estado haciendo el doctor Yasser El Sayed en este magnífico artículo donde se hace un abordaje basado en ultrasonido, pero también es un abordaje integral tomando en cuenta marcadores clínicos y bioquímicos. Los marcadores por ultrasonido que podemos buscar para enterocolitis son los siguientes. Primero, los que representarían una urgencia y se pueden buscar en todo aquel neonato que tiene una descompensación súbita, como son la neumatosis porta, la presencia de líquido libre, y este puede ser simple cuando vemos un fondo negro o complejo cuando vemos ecos en su interior, y la presencia de aire libre, que como vamos a ver no es tan sencillo de diagnosticar por ultrasonido y dependemos de la placa de tórax. También podemos valorar la peristalsis, la presencia de firma intestinal, que ahorita vamos a ver qué es, si hay o no neumatosis intestinal por ultrasonido, si el intestino está engrosado, si el intestino está adelgazado y los patrones de perfusión, si es normal, si es anormal o si hay una perfusión ausente. Esto es mucho más sencillo si tenemos un transductor lineal y básicamente vamos a explorar los 4 cuadrantes del abdomen, derecho superior inferior e izquierdo superior inferior. Y podemos hacer barridos transversales y longitudinales. Y podemos tener una hoja de captura de datos donde vamos a poner los cuadrantes que estamos explorando y si estamos encontrando la presencia o ausencia ya sea de gas portal, dolor a la palpación. Esto es muy importante. Cuando estamos haciendo nuestro examen por ultrasonido abdominal, también valoramos la presencia o no de dolor a la manipulación. Si vamos a encontrar líquido o aire libre, y vamos a también valorar la presencia o no de la ecotextura de la pared abdominal, es decir, la firma intestinal, que ahorita vamos a ver. ¿Cuál es el grosor? La peristalsis, que normalmente debemos de ver más de 10 movimientos peristálticos por minuto, la presencia de neumatosis intestinal y la perfusión. Para hacer la primera fase, que es lo que les comentaba como que lo podemos tomar como algo urgente, Podemos usar algunas sondas curvilíneas de baja frecuencia, 4 a 8 Hz. Y para la fase 2 vamos a necesitar transductores lineales de alta resolución que vayan de 8 a 20 Hz. Es un ejemplo de cómo podemos verlo en una situación urgente. Neonato de 33 semanas de gestación, 14 días de vida con descompensación cardiovascular y distensión abdominal, pasa de unidad de cuidados intensivos intermedios a unidad de cuidados intensivos. Vean cómo con el ultrasonido pues vemos que el paciente está intubado, que el tubo está adecuadamente colocado a 1 centímetro más o menos del arco aórtico. Como vemos rápidamente que hay deslizamiento pleural bilateral para descartar la presencia de neumotórax o de derrame pleural importante. Este paciente inicialmente estaba en actividad eléctrica sin pulso. Se comienza la reanimación y vean cómo utilizamos una imagen de 4 cámaras y vamos guiando la reanimación hídrica de este paciente. Pero como desde que pasamos por el cuadrante superior derecho, vemos que hay neumatosis porta de manera importante. Y en el cuadrante inferior derecho podemos identificar estas asas totalmente adelgazadas con neumatosis intestinal que se corroboran a la hora de hacer la laparotomía. Entonces la neumatosis porta pues es algo que se puede ver relativamente sencillo. Tenemos la textura del hígado que es gris y estos puntitos blancos que viajan hasta la periferia y podemos ver incluso las burbujas de aire viajando a través de la porta. Y la búsqueda del líquido libre pues es relativamente sencillo, sobre todo lo buscamos en los cuadrantes inferiores derecho e izquierdo lateral. Muchas veces también localizamos la vejiga, vemos que hay orina o no en la vejiga y de ahí nos vamos a ambos flancos y diferenciamos del líquido simple a el líquido libre complejo. Aquí en estos dos ejemplos podemos ver textura, ecotextura dentro del líquido, entonces ambos son complejos y aquí además vemos fibrina, adherencias, complicaciones, enterocolitis complicadas. Y en la tercera fase sería ver si hay datos de aire libre. Esto puede ser extremadamente complejo por ultrasonido. Hay que entender muy bien la física y los artefactos. Entonces, inicialmente no podemos no depender de la placa de abdomen también para hacer este diagnóstico. El artefacto A es muy frecuente que lo veamos en la valoración intestinal y esto no implica que haya una perforación intestinal, simplemente quiere decir que estamos encontrando una colección de aire que hace que el sonido al rebotar contra el aire, no rebotar contra interfase aire líquido, se reproduzca estos artefactos equidistantes que conocemos como el artefacto A. Aquí podemos ver cómo hay líquido libre y de repente nos aparece un artefacto A. Cuando hay perforación intestinal, vamos a encontrar esta línea hiperecogénica posterior a la pared abdominal anterior y muchas veces nos puede dar efecto también de cola de cometa. Este es un prematuro de 28 semanas de gestación con SDR modificado por surfactante. Se deteriora al día 17 con aumento de la presión del perímetro abdominal de 3 centímetros. En la valoración hemodinámica lo encontramos con circulación hiperdinámica, con hipotensión que mejora tras la administración de volumen. Y esta circulación hiperdinámica y las paredes que se tocan en sístole y que genera aceleración en medio de la cavidad es un patrón que se ve habitualmente en las fases agudas de la enterocolitis. Y como pueden ver, este paciente tenía una perforación intestinal, una enterocolitis complicada. Es común que los pacientes con lesión intestinal también puedan tener efecto en otros órganos y sistemas. Aquí les demuestro cómo genera un SDRA, un síndrome de dificultad respiratoria agudo. Vean cómo hay un incremento del número de líneas B llegando casi a pulmón blanco. Y en el abdomen vean cómo tenemos las asas con neumatosis intestinal. Y aquí podemos ver el artefacto A, pero se identifican las burbujas a nivel de la pared que nos demostrarían una perforación intestinal o aire libre. Es frecuente que tomemos el tronco celíaco y la mesentérica superior en las valoraciones hemodinámicas, pero es muy importante establecer que no se ha encontrado ninguna correlación del Doppler de estas con la predicción de intolerancia a la alimentación o la presentación de enterocolitis necrosante. Generalmente vamos a encontrar Dopplers normales o vamos a encontrar un poquito de vasodilatación, incluso en el tronco celíaco y en la mesentérica superior, y no son vasos que nos sirvan mucho para el diagnóstico de la enterocolitis. Y finalmente, lo que yo creo que es más complicado es poder ver propiamente el intestino. Y aquí vamos a ver lo que es la firma intestinal. Normalmente vamos a ver las 5 capas: la mucosa, la muscular de la mucosa, la submucosa, la muscular propia y la serosa. Lo importante aquí es que en general las capas musculares, al estar mejor perfundidas o más perfundidas, las vamos a ver hipoecoicas. Cuando hay una alteración en la perfusión, se pierden estas áreas hipoecoicas y esta diferenciación de las capas, y vamos a ver toda la textura pareja. Entonces aquí podemos ver cómo normalmente vamos a ver las 5 capas, y cuando comienza a haber hipoperfusión del intestino, se pierde esta firma intestinal porque las zonas que están mejor perfundidas se pierden. Esa mejor perfusión normalmente nos da áreas hipoecoicas que se pierden y perdemos también la diferenciación. Y lo que habíamos visto, normalmente el intestino va a medir entre 1 y 2.6 milímetros. Entonces aquí tenemos un caso donde puede haber duda de si existe o no neumatosis, y cómo el ultrasonido intestinal es útil para demostrar que no hay neumatosis y podemos identificar las diferentes capas, incluyendo las que son hipoecoicas. Ahora, para diagnosticar neumatosis intestinal necesitamos identificar estos puntitos blancos, que sería el aire. El aire se ve blanco cuando está contenido en una víscera. Por eso se ve así la neumatosis porta. Y en la neumatosis intestinal es muy importante identificar que se encuentran estos puntos en la pared del intestino, es decir, son intramurales. Es muy común que haya contenido intraluminal hiperecogénico, pero cuando nos quedamos viendo el suficiente tiempo, vemos cómo este contenido intraluminal viaja y esos puntitos blancos están dentro de la luz y desaparecen. Aquí podemos ver igual una placa que puede no decirnos mucho, pero identificamos perfectamente la asa intestinal engrosada y con esos puntos blancos que están dentro de la pared intestinal, y esto es neumatosis intestinal. El ultrasonido es muy sensible para identificarlo, pero el arte de ver el intestino es saber manejar la sonda, tener gel y manos calientes y poder librar los artefactos para poder identificar el intestino. Entonces aquí podemos ver intestino engrosado y con los puntitos blancos que están dentro de la pared intestinal. Este es un ejemplo de un paciente que en la primera valoración intestinal había demasiado artefacto A. Era un paciente séptico con neumonía que tenía distensión abdominal, y en el primer reporte pusimos eso, que había abundante artefacto A y no éramos capaces de ver bien las áreas de intestino, y en la siguiente valoración al día siguiente sí podemos identificar como si había zonas con neumatosis intestinal. Y es bastante sensible el ultrasonido. Como ejemplo, este es un prematuro con restricción de crecimiento intra y extrauterino, 30 semanas con 32 corregidas. Tuvo manejo para conducto arterioso permeable relacionado a la prematuridad, persiste con bicarbonatos bajos, se aborda para infección, se progresa hasta meropenem y se sospecha un foco abdominal. En la guardia tiene incremento de requerimientos de FiO2 arriba del 60%, y tenía hipertensión pulmonar, desaturaciones, y vean cómo en la valoración intestinal vemos que no hay gas portal, no hay líquido libre, y el intestino, a pesar de que estaba con la peristalsis muy disminuida, tenía un hileo séptico, no identificamos neumatosis intestinal. El patrón de perfusión era hiperémico. y el paciente, digo, por gravedad, acabó en una laparotomía exploradora donde se corroboró que no había lesión intestinal. Comparado con este otro caso, trillizo 1 de 28 semanas, 4 días con 3 de estancia intrahospitalaria, con distensión abdominal, dibujo de asa, había alto riesgo de un conducto que demostramos que estaba permeable y hemodinámicamente significativo y no tenía hemorragia intraventricular. Pero vean cómo también desde la valoración intestinal pues encontramos que hay neumatosis porta, asas adelgazadas con neumatosis intestinal y que se corrobora al momento de la laparotomía. Y el patrón de hiperemia y ven la presencia de neumatosis intestinal. Y finalmente, pues podemos tratar de ver cuál es la perfusión del intestino directamente con un transductor lineal. Necesitamos ajustar nuestra escala de Doppler color de 0.029 a 0.11 metros sobre segundo. Y lo importante es identificar el grosor que ya platicamos, de 1 a 2.6. Normal, vamos a tener de 1 a 9 puntos de color. Lo que pasa en las etapas iniciales de la enterocolitis es que vamos a tener un intestino engrosado con un patrón de hiperemia. Posteriormente vamos a tener un intestino engrosado con patrón de isquemia. Después vamos a tener un intestino adelgazado con patrón de isquemia hasta tener un intestino totalmente adelgazado sin perfusión. Y aquí les pongo ejemplos de pacientes con enterocolitis, la presencia de neumatosis intestinal y el patrón de hiperemia. O también estas asas muy adelgazadas, vean cómo miden 0.3 milímetros y 1 milímetro y el patrón de perfusión está disminuido. O este otro caso, ¿no? Vean cómo tenemos un intestino muy adelgazado, 0.6 milímetros, con un patrón hiperémico, con ausencia de peristalsis y movimiento del contenido intraluminal únicamente. En el Instituto Nacional de Perinatología, de octubre del 2023 a febrero del 2024, de 211 interconsultas de ultrasonido, 54 han incluido valoraciones abdominales, se han diagnosticado 10 enterocolitis, 4 complicadas. Y es muy importante recordar que esto es un complemento a lo que hacemos normalmente. Entonces debe de existir la valoración clínica, debemos de hacer nuestra exploración abdominal y pedir también los laboratorios que normalmente tomemos, la valoración radiológica y una participación muy cercana de cirugía neonatal. Generalmente cuando trabajamos con los cirujanos neonatales pues vamos de la mano y esta herramienta también es de ellos como una herramienta en el punto de cuidado del paciente para poder extender nuestra valoración clínica y buscar más datos. Muchas gracias.
Hi and welcome everyone. I will discuss in this presentation assessment of gut injury by ultrasound. I will discuss gut injury in general and necrotizing enterocolitis in particular. I have nothing to disclose in this presentation. And I have 3 main objectives. First, I will discuss triggers and pathogenesis of gut injury. It is very important to understand the intestinal ultrasound markers based on understanding pathogenesis of gut injury. Then I will discuss intestinal ultrasound in details. Then I will discuss the impact of integrating ultrasound to other clinical and biochemical markers, the impact of this integrated approach on clinical outcomes. There is no any single standard diagnostic marker for diagnosis of neck or gut injury. That's why we are relying on our model on integrating clinical, which is the most important, to intestinal ultrasound, laboratory markers, and abdominal X-ray. We need to integrate all of these modalities to understand the underlying severity of gut injury and also to understand the appropriate interventions, including restart of feeding or the extreme, which is surgical intervention. I have sectioned this presentation into 3 main sections according to the 3 objectives. The first section is the introduction about the common triggers of gut injury and pathogenesis of gut injury. So we have 4 main triggers of gut injury. The first trigger is delayed feeding associated gut injury. Second is lymphocytosis associated gut injury. Third is food protein induced enterocolitis, or the other name is cow milk protein allergy. And the fourth type is ischemic gut injury. So let us discuss one by one. The first trigger is delayed feeding associated gut injury. Delayed feeding usually affecting premature infant or low birth weight infant. And delayed feeding might be aggravated if it is associated with prenatal use of antibiotics. This might induce mucosal atrophy. It might change flora phenotype as a mechanism, and mucosal breach by flora might follow. That it might take few weeks. That's why we are usually expecting that few weeks after birth in premature infants, around corrected age or post-menstrual age 30 to 32 weeks. This type of injury triggered by non-ischemic baseline. So prenatal use of antibiotics or delayed feeding is non-ischemic baseline, but subsequently the gut injury might be directly secondary to decreased blood flow or decreased blood supply, ischemia, and decreased oxygen delivery. At the end, the extreme scenarios gut necrosis and perforation. So this is the first type. The second mechanism is lymphocytosis associated gut injury. This trigger is not well understood. It might be associated with a viral infection, and it might happen in premature infant and also might happen in term infant. Lymphocytosis associated gut injury or NIC. It could be, as I mentioned, induced by viral infection or aggressive feeding with increased lymphocytes. It is associated with a mucosal breach by flora, usually around 29 to 32 weeks post-menstrual age. Similar to the previous type, the trigger is non-ischemic baseline trigger, but eventually the gut might be exposed to decreased blood flow or decreased oxygen delivery, gut ischemia, gut necrosis, and subsequent perforation as the expected extreme scenario. We may see in ICU one infant affected with NIC, and shortly after that we may see another infant beside this baby developed also NIC with unknown mechanism. It might be induced by a transmitted viral infection from infant to infant. The third trigger is food protein induced enterocolitis, or as known to a lot of our colleagues as cow milk protein allergy. So cow milk might be related to formula feed based on cow milk protein, or the milk fortifier that we are adding to breast milk. And sometimes also might be associated with breast milk, especially with mothers on dairy products. It is associated with a high level of eosinophils, which might be recruited to mucosa with thrombocytosis. There is one of the very common markers to differentiate classic NEC from food protein induced enterocolitis. Usually in classic NEC we have thrombocytopenia, but with food protein induced enterocolitis we may expect thrombocytosis plus high eosinophil count. Usually the infant with the food protein induced enterocolitis is more stable. Clinically there is no significant hypotension, and the intervention in this case should be focusing to change formula or modify formula, not to keep the infant MPO, which might actually trigger more gut injury. Again, mucosal breach by flora at variable time. This trigger is non-ischemic, and at the end gut injury might be affected by ischemia, but it is usually very mild in this type of gut injury. The last trigger is ischemic gut injury. So it is direct ischemia. It could be acute ischemia or chronic ischemia. It might happen secondary to congenital cyanotic heart disease or decreased blood flow in interrupted aortic arch on hypoxic ischemic encephalopathy. So it is hypoxic ischemia, and if it is associated also with aggressive start of formula feeds, might induce gut injury. Again, it might be associated with mucosal breach by flora about 5 to 7 days after injury. So this type of gut injury expected to happen shortly after triggering by ischemia, especially in acute type of ischemia. This is the only gut injury with the trigger is ischemic as a baseline, and also the disease state or gut injury type at the end is also ischemic. Now we can classify intestinal injury into 4 main categories. Necrotizing enterocolitis or typical necrotizing enterocolitis in low birth weight infant or premature infant. The second common type is compromised oxygen delivery, compromised by decreased oxygen saturation, like in severe hypoxemia, for example congenital cyanotic heart disease, or severe hypoxemic respiratory failure. Could be associated with severe anemia as well. Could be associated with shock or decreased blood flow. We consider in our unit for an infant with shock to assess gut injury by ultrasound. It could be also associated with hypoxic ischemic encephalopathy. And then we have the third type, intestinal obstruction, and there is 2 types of gut injury associated with intestinal obstruction. The acute or surgical emergency type with twist of bowel, twist of blood vessels at the same time, for example in volvulus or malrotation. This surgical emergency because if you wait few hours, it might be associated with significant loss of bowel or necrosis. So this condition should be intervened early. Obstruction also might be associated or secondary to strictures, which is not really surgical emergency. The operation might be considered on elective basis. Stricture or adhesions might follow any type of gut injury, and usually happens a few weeks after recovery from acute gut injury. And we'll discuss that in more details. Then food protein induced enterocolitis, which is not really severe form of injury, and we don't have again to consider MPO or antibiotics in this condition. We need just to modify formula to hypoallergic or elemental formula. Now we need to understand the link between pathogenesis of gut injury and intestinal ultrasound markers. And for that we have three main stages. The first is mild gut injury, early gut injury. Then we have severe gut injury. And then we have pathogenesis of adhesions and strictures later on. So let us discuss one by one. First, we'll discuss pathogenesis of the first stage, which is early mild gut injury. And for each stage, early or severe, we'll discuss three main changes. Changes related to smooth muscle, changes related to increased secretions or secretory changes, and then vasoactive changes. The musculosa is the most sensitive part of the intestinal wall to ischemia. As we will discuss later, we have 5 layers of intestinal wall. One of them, the most sensitive one, is musculosa. Why? Because the musculosa is receiving a substantial amount of blood flow. A very vascular layer receiving a lot of blood flow. That's why this layer is very sensitive to any type of ischemia. And with mild gut injury, the muscle spasm might happen with increased thickening of the wall. So when we assess ultrasound in early or mild cases of gut injury, we'll see thickening of the intestinal wall or sluggish peristalsis. So the spasm will cause decreased peristalsis and thickening of the wall. And then another change expected to happen in mild cases, increased intestinal secretions. In severe cases, we'll see the secretions outside the intestinal loops in the peritoneal cavity. So we'll see more ascites, which could be complex, significant ascites. In mild cases, the secretions will be increased intraluminal, inside the intestinal loops. And these secretions should be induced by multiple markers or mediators. The most important one is the vasoactive intestinal peptide. What's the value of these secretions? It's very helpful actually to dilute toxins and dilute the other transmitters that might actually affect or cause more ongoing intestinal injury. And then vasoactive intestinal peptide might actually cause more vasodilator or increase the blood flow or hyperemia. So in early gut injury, we'll see more blood flow or hyperemia induced by vasoactive intestinal peptides. Hyperemia actually might help in recovery of gut injury and usually associated with early gut injury or mild cases. Then in severe cases, we may see the same 3 categories of changes, but with different kind of changes compared to mild gut injury. Regarding the smooth muscle, we'll see more relaxation instead of spasm. Relaxation will be associated with thinning. So we'll see in the intestinal ultrasound thinning of the wall, which is a lit sign and bad sign as well. It could be associated with intestinal necrosis. And instead of weak peristalsis or slow peristalsis, we'll see absent peristalsis, no peristalsis in late stages. Secretions will be increased and will be not only intraluminal, will be also in the peritoneal cavity. And this kind of significant increase in secretions will be induced by bradykinin, induced also by tumor necrosis factor alpha, interleukins, and might cause significant complex peritoneal fluids. Later on, we'll see that this complex peritoneal fluids might induce adhesions and also might cause a stricture of the intestinal loops later on after recovery from the acute stage. The vasoactive changes, early stages, we mentioned about hyperemia, but in later stages of NEC, we'll see vasoconstrictor effect or vasoconstrictor ischemia secondary to secondary to endothelin 1, which is very strong vasoconstrictor mediator, and it is very or kind of easy to see that by ultrasound, and to differentiate between mild gut injury with more hyperemia and thickening to severe late gut injury with thinning of the wall, no peristalsis, and ischemia instead of hyperemia. What about pathogenesis of adhesions and stricture with the complex peritoneal fluids around the intestinal loops? This peritoneal fluid might actually dry or organize over time and cause twisting of the walls, and also with longitudinal and circular muscle spasm of the intestinal loops. And this spasm might happen in longitudinal fashion, as you can see, or circular fashion. And this long standing muscle spasm might cause later on during recovery strictures. Muscle spasm might complicate the situation and cause a stricture, and this stricture will be presented once you start feeding later on with the intestinal obstruction. So now we understand the three main categories or stages of gut injury according to severity: mild early type, severe type, and also later on after recovery with the acute stage with adhesions and strictures. I have two case scenarios to clarify the limitation of relying only on abdominal X-ray, and also to clarify how we can integrate intestinal ultrasound to clinical assessment, and also to formulate a logical medical recommendation. So we have preterm 30 weeks at birth. 2 weeks later, this infant started to pass multiple frank blood per rectum. CRP was 6, repeated twice, with unremarkable CBC and blood gases. And we have this X-ray here, and this X-ray was interpreted by the pediatric radiologist and also by the neonatologist as hematosis intestinalis. And in the X-ray, one of the main limitations in the X-ray, you may interpret the presence of air between the fecal contents and the intestinal wall as pneumatosis. It might not be really true pneumatosis. And the blood stool might be related to protein allergy, or might be related to any other reason, like rectal injury or fissure, anal fissure, for example. When we did an intestinal ultrasound 6 hours later after the X-ray, the ultrasound actually was focusing on the same area, left upper quadrant, the same area of concern in the X-ray. I can see very good perfusion, normal intestinal peristalsis and movement. There is no any pneumatosis can be seen. So a very reassuring intestinal ultrasound. And we considered to start feeding after that, and the feeding was tolerated without any issue. Then I have another case scenario. Preterm 26 weeks at birth, hemodynamically stable at 2 weeks of age, developed pancytopenia with high CRP. CRP was initially 196 and rising, but no lactic acidosis in the blood gas. And the X-ray, although the X-ray is abnormal, but we can't see any specific marker for neck. There is no hematosis intestinalis, there is no portal venous gas or perforation. And then the ultrasound was showing severe gut injury, very echogenic bowel, septated peritoneal fluid, no color Doppler, ischemia by color Doppler. So the markers that are consistent with severe type of gut injury or severe neck. Later on, this infant required operation with substantial part of the bowel removed, unfortunately, due to patchy ischemia and necrosis of the small bowel in this case. Now let us discuss how to integrate intestinal ultrasound to other clinical markers in assessment of gut injury, or the integrated approach. First, we have to emphasize that abdominal X-ray in comparison to intestinal ultrasound is very limited. And we have a lot of literature discussed the limited agreement between different disciplines, including neonatologists, radiologists at different levels, including neonatal fellows and pediatric residents, with very poor agreement between them regarding assessment of different X-ray markers, nematosis intestinalis, portal venous gas, even perforation, and in diagnosis of necrotizing enterocolitis at the end. And we have seen in our experience so many X-rays reported, as you can see here, by the radiologist as nematosis intestinalis, and the ultrasound confirmed normal or no gut injury, and we considered to start feeding. And we have, for the last almost 4 years, we have all of these infants tolerated feeding without any complications. So we did actually assessment or data analysis for the cases in our unit, and we have seen that ultrasound was normal in about 44% of the X-rays reported as neck. That's almost close to almost half of the cases reported as neck by X-rays. And all of these cases refer to point of care assessment. And we consider to start feeding with just short period of MPO until the ultrasound confirmed normal gut performance. We started feeding in all of them, and the maximum, as I mentioned before, could be some cases with the food protein induced enterocolitis, and then management should consider a change of the formula not to keep the infant MPO. We need to integrate between clinical signs, biochemical markers, and ultrasound. And unfortunately, all of the clinical signs, biochemical markers are non-specific, including intestinal signs of blood stools, abdominal distension, vomiting, abdominal cellulitis may be more specific and more important. When you have this sign, you have to pay attention because it's very common associated with severe gut injury. Systemic signs could be tachycardia, bradycardia, apneas, lethargy, or temperature instability. Biochemical markers, all are non-specific markers of inflammation or markers of ischemic injury, including CBC, CRP, genomic markers for pro-inflammatory responses, and we are not using that as a routine yet. And then respiratory and metabolic acidosis might be associated with gut injury, or lactic acidosis and neutropenia. Coagulopathy as well might be associated with severe cases of neck or gut injury. We have 4 main watershed areas which might be affected with gut injury more than other areas of the intestine. So watershed areas, just to simplify the physiology of watershed, we have 3 side by side three areas or three categories of tissues side by side. We have area number 1, 2, and 3. There is a specific blood supply for area number 1 and another specific blood supply for area number 2, but area number 3 is relying on the terminal blood supply from the artery number 1 and artery number 2. In normal situation there is no problem, but in case of shock or decreased blood flow, the most specific or most sensitive area to be affected with injury or ischemia is area number 3, which is watershed area. So we have the ileocecal area, is watershed area, the hepatic flexure, splenic flexure, and the lower part of the descending colon. Assessment of ultrasound can be categorized into 12 markers. So free air can be seen by ultrasound, although X-ray is reliable to evaluate free air or perforation. Mural gases or pneumatosis intestinalis can be seen by ultrasound, but one of the limitations that sometimes is very difficult, especially for the beginners, to differentiate between pneumatosis intestinalis and the air as artifacts. Portal venous gases is much easier to detect by ultrasound, and you can detect even mild cases, and only severe cases can be the portal venous gas can be seen on the X-ray. Thickened bowel, and we are using 0.26 centimeter as cut limit for normal bowel thickness as the upper limit, and the lower limit is 0.11 centimeters. Below that is thinning of the bowel. Again, thickening is early sign, thinning is late sign. Peristalsis can be assessed. You cannot assess peristalsis by X-ray. And intestinal signature, and we'll discuss that later. And we may see fluids. Fluids might be complex fluid or just mild simple peritoneal fluid. By applying color Doppler, we can see good perfusion. And if you see 3 to 9, at least 3 to 9 speckles, this is normal. Color Doppler, a speckle of color. By applying 2 by 2 color box. And then if you see hyperemia, which could be different types, can be Y-shaped hyperemia, or circle hyperemia, or zebra hyperemia. 3 main types of hyperemia. If you apply color Doppler and you cannot see any color at all, this can be considered as a sign of severe ischemia or absent color flow due to severe ischemia. So we have the 3 categories. We categorized ultrasound for simplification into 3 main categories. You can differentiate between jejunum and ileum by ultrasound. So the jejunum is occupying the left upper part of the abdomen. The jejunum is mainly the lower right part of the abdomen. The ileum is smooth from inside, as you can see here in this image with dilated ileal loops. Is abnormally dilated, but just to clarify that the ileal wall from inside is more smooth compared to jejunum. Jejunum, you can see some ridges, and these ridges are representing intestinal villi or plicae circularis. And the plicae circularis will give the impression that the jejunum is more thicker by ultrasound, but should not exceed the upper limit of normal, which is 0.26 in even term infant. In this slide, we'll discuss how to perform ultrasound as a technique in brief. So we can divide the abdomen into 4 main compartments, and also we can add the periumbilical area or midgut area. So the abdomen is right upper quadrant, right lower quadrant, left upper, left lower, and it's very important to evaluate the liver for portal venous gas. With ultrasound, we need to apply the ultrasound probe in 3 different planes: the sagittal plane or longitudinal plane, the transverse or cross-sectional plane, and the coronal, or from the side, the coronal plane. So you have the sagittal, the green plane is transverse, and then the coronal plane from side to side. The sagittal and the transverse planes are the most important in assessment of liver. So assess the right lobe in both longitudinal and or sagittal and transverse. Left lobe the same, longitudinal or sagittal and transverse. And we need to assess for any evidence of portal venous gas in the liver. And if you see any abnormal thrombi or any abnormality in the gallbladder or so, you need to refer that to the radiologist to do like more detailed assessment by the radiologist with full ultrasound of the liver compartments and the structure. And also you need to assess the right upper quadrant and all of the other quadrants in sagittal and the transverse planes, and also the periumbilical area. The colon, the ascending colon and descending colon, they are more lateral or to the side. So you need to move the probe to the coronal plane to see the colon and the longitudinal section. Or remove the probe transverse, you can see the colon as circles. It is easier to assess the ascending and the descending colons. Transverse is more difficult because the shadow from the air in the stomach, but you can see the hepatic flexure and splenic flexure easier by ultrasound. Now let us discuss the intestinal ultrasound markers one by one. So we have nematosis intestinalis, portal venous gas, peristalsis, present or absent, or maybe slow peristalsis, intestinal signature, intestinal wall, thickening or thinning, assessment of perfusion by color Doppler, presence of peritoneal fluids or ascites, perforation, although it's better to assess perforation by X-ray. And then if you have near-field spectroscopy, also you can assess gut ischemia by adding near-field spectroscopy to ultrasound. And then we need to differentiate between true nematosis and false nematosis. As you can see here with the nematosis intestinalis, echogenic tiny small bubbles around the lumen or inside the intestinal wall in multiple loops. Also in this loop you can see the typical true nematosis, and also in this multiple loops, abnormal loops surrounded by peritoneal fluids with this loop with severe or significant nematosis intestinalis. Typically with a true nematosis in gut injury, it is almost difficult or should not be seen without any other markers of gut injury. Nematosis should be associated with other markers like peritoneal fluids, ischemia, thickening, thinning. If you see only nematosis or suspicion of nematosis and there is no any other markers with good peristalsis, this is most probably false nematosis or artifacts. So let us see what our artifacts looks like. So here you can see good peristalsis, moving bowel, and there is area here of suspicion. This area with some bubbles, and if you apply the pressure by the probe, you can move easily, see the intestinal artifacts moving away from the this image, which signifying artifacts more than nematosis. So let us see that again. Applying some pressure with my hand, as you can see, the air artifacts disappeared within few seconds. So we need to differentiate between true nematosis in gut injury and false nematosis or air bubbles artifacts because of presence of air inside the intestinal lumen. Then we'll discuss the next marker, which is portal venous gas. Portal venous gas can be massive. As you can see, a lot of bubbles moving in all directions in the portal veins inside the liver, or could be moderate. Less significant bubbles moving also in the liver in different directions, or could be mild. You can see just a few small bubbles moving in the liver. Mild portal venous gas is usually missed by X-ray. You can detect by X-ray massive portal venous gas or even moderate portal venous gas. But this typical case with the mild portal venous gas was missed by X-ray done at the same time. So it is easy to miss mild portal venous gas. Ultrasound is very sensitive to detect even very mild cases of portal venous gas. Then next, let us discuss peristalsis. So I'll just show you a clip with normal peristalsis. You can see the very nice hypoechoic normal bowel with the good peristalsis, which is different from this clip with absent peristalsis. You can see just a pulsation from the abdominal aorta, just pulsation, but there is no any effective movement of the gut, and very echogenic severe gut injury. As you can see, very echogenic bowel due to severe gut injury. And then the other type of peristalsis could be obstructive peristalsis. When you see dilated jejunal loop, as you can see here, and the intestinal contents moving in both directions, back and forth, not effective forward one direction peristalsis. This could be, or most probably related to distal obstruction, distal to this loop. So we have now good understanding how to differentiate between normal peristalsis, absent peristalsis, and obstructive peristalsis. Then next we'll discuss intestinal signature. Intestinal signature means that you can differentiate the intestinal wall layers. We have two hypoechoic layers, musculosa and mucosa, and the three echogenic or bright layers. So overall we have 5 layers. First, the mucosal interface. Echogenic layer, it is interface between the mucosa and the intestinal contents. Next, number 2, the mucosa, which is also hypoechoic. Hypoechoic dark in the ultrasound because it is receiving good amount of blood supply, the same like musculosa. And then we have submucosa, more echogenic or bright, and then we have the musculosa, more thickened compared to mucosa and also hypoechoic, and the 5th layer is serosa at the end. If you're able to differentiate the layers clearly, it means you have impression of normal intestinal signature or normal bowel wall, because in ischemia you cannot differentiate between these layers, because everything will be echogenic, everything will be with low blood flow, so the musculosa will lose the hypoechoic nature and will be more bright. Then next we'll discuss intestinal wall. In intestinal wall assessment, we have to differentiate between normal intestinal wall, thickening of the wall, and thinning of the wall. And remember, for any of the previously mentioned markers and the upcoming markers, we have to assess 4 quadrants: right upper, right lower, left upper, left lower, and also you may add the periumbilical area or the midgut. And you have this loop here, the jejunal loop, which is really thickened and measured as 0.35 compared to this thin wall of the colon, which is only 0.09 centimeter or 0.9 millimeter, very thin, surrounded by peritoneal fluid. And also in this abnormal loop, with the thickening, you cannot differentiate the layers because of the significant bowel ischemia. Also here in this thin wall of the colon, you cannot differentiate the layers. It's just one echogenic layer. So we have at least two markers can be appreciated in this image: thickening and loss of intestinal signature. Here you have thinning, loss of intestinal signature, and the peritoneal fluids, and also dilated intestinal loop. Remember to evaluate any one of the previously mentioned markers in the 4 quadrants: right upper, right lower, left upper, left lower. Next, we'll discuss perfusion by color Doppler. Perfusion, we need to differentiate between normal hyperemia and hyperemia, as you can see, Y-shaped hyperemia, and in between very echogenic bowel wall, and you cannot differentiate any intestinal signature here. And also ischemia. Ischemia will be the opposite. No color Doppler can be detected, only some artifacts here, but no typical speckles or even hyperemia. This infant with significant ischemia operated almost 30 minutes after this ultrasound. And with this significant ischemia represented with pathology or during OR, as you can see, discolored bowel with like dark or gray color bowel due to ischemia, and you have different levels of ischemia. This bowel loop here looks pink or normal compared to gray hypoperfused bowel, and other loops here with also gray but less severe ischemia. There is the same infant with this ultrasound performed just shortly before OR. And then we'll discuss ascites or peritoneal fluids next. We have to differentiate between luminal fluid, which is more kind of circle fluids in this cross-section image of colon, and you can see the shredded mucosa of the colon. You have the peritoneal fluid, which is can be differentiated with acute angles or irregular angles of the sides. So that's the peritoneal fluid here, side by side with luminal fluid in this infant with severe gut injury. Next, we'll discuss perforation. Again, remember that perforation is better to be assessed by X-ray. That's why with any infant with the severe gut injury, we'll consider abdominal X-ray to be done frequently to assess any perforation that might happen at any time. So you have in this image here air artifacts over the liver due to perforation, and also you have another image here with air artifacts due to significant perforation. The middle example here is different. The air was encysted inside the bowel, between the bowel loops, and this perforation initially was missed by X-ray, was detected by ultrasound, because the air was encysted, not really free air that can be detected by X-ray. If you have near-field spectroscopy, also you can assess bowel ischemia. But one of the limitations of near-field spectroscopy, that if you are assessing any area with the fluids or air content, you can detect only the reflection of the or perception from the air artifacts, not actually from the ischemic bowel. That's why it's very important to assess by ultrasound first, to be sure that you are applying the probe over tissues or over intestinal loops, not over fluids like here. So here is more reliable because you are assessing area with tissues and there is no fluids or air, so the perception of the near-field spectroscopy will be typically from tissues, not from fluids, as you can see here. And we are relying on both saturation and fractional oxygen extraction. If the saturation is in 60%, in mild cases less than 50% in severe cases, this is considered as a marker of severe ischemia. But remember that once you have the intestinal loops necrotic or gangrenous, then you should not expect any increased extraction or any even normal extraction with oxygen. Then you may have the oxygen saturation even higher than normal or almost similar to the arterial oxygen saturation. So with the typical ischemia, you will see low oxygen saturation on near-field spectroscopy with increased fractional oxygen extraction more than 0.3 or more than 30%. And in necrosis or severe gut injury with gangrenous bowel, you will see the oxygen saturation very high and with very low fractional oxygen extraction. If we integrate between thickening of the bowel and the color Doppler, we can actually consider a very nice, reliable grading of ischemia, which has been published. So normally we have normal speckles of color, 3 to 9 as I mentioned, and normal thickness of the bowel. Early gut injury, you can see thickened bowel with hyperemia, or could be thickened with ischemia, which is more late. And then we have thinning of ischemia, or could be severe ischemia. When you see a very thin bowel wall with no color Doppler at all, that could be just a necrotic bowel segment or wall. Now section number 3. So we'll go over the outcome of integrated approach. So we assessed in our unit 144 cases assessed from 2016 to 2020 in 2 hospitals, and we evaluated or classified the gut injury based on the outcome. So if the infant continued feeding with normal ultrasound and feeding was well tolerated, we consider that as normal, although we have significant number of cases with abnormal X-rays reported as nematosis. That's why we consider that intestinal ultrasound is superior to X-ray in assessment of gut injury before perforation, because perforation, again, we should rely on X-ray. And then if the infant was clinically consistent with food protein induced enterocolitis and the formula changed to hypoallergic and the infant improved, or the symptoms improved with the improvement blood stools, abdominal distensions, and biochemical markers, eosinophilia, and so on, we consider that as confirmed food protein induced enterocolitis. And then if the ultrasound was consistent with early mild gut injury or NEC, and the infant tolerated feeding after a variable period of MPO, usually maximum 7 days, 5 to 7 days, we consider that as mild gut injury. But if the infant required surgery later on after improvement due to stricture or adhesions, we consider that as moderate gut injury. But if the infant required urgent surgery due to severe ischemia, severe bowel or gut injury with resected part of the bowel, we consider that as severe type of gut injury. We compared intestinal ultrasound severity score with the classes of gut injury, and the score was significantly higher in severe cases compared to moderate and mild cases, and score of 0 in normal cases. X-ray score, which was based on pneumatosis intestinalis, portal venous gas, or perforation, did not differentiate between normal, mild, and moderate cases. Only the score was significant in severe cases of neck. Eosinophil count was reported in literature as a reliable marker of food protein-induced enterocolitis, and the ultrasound score was significantly higher with high eosinophil count, and the X-ray score did not show any significant difference between normal cases and food protein-induced enterocolitis. This slide summarizes the integrated algorithm management for gut injury. If there is clinical suspicion of neck or gut injury, we'll consider gut injury workup, including CPC, electrolytes, CRP, X-ray, and intestinal ultrasound, after consulting the physician responsible for this integrated approach. If the infant is symptomatic but stable with normal ultrasound plus normal lab work, we'll consider to start feeding or continue feeding without interruption. If the infant is symptomatic, stable, with lab work consistent with food protein-induced enterocolitis, we'll consider elemental formula for 7 days as a trial to see if the infant will improve on that or not, and then advocate mother to quit dairy products if she would like to continue breastfeeding and restart breast milk after that. If the infant is symptomatic but unstable with respiratory or hemodynamic instability happening at the same time of suspicion of neck, or with abdominal cellulitis, together with mild ultrasound markers and lab work consistent with neck, will continue MPO for a variable period of time until we have the lab work normalized with normal ultrasound, and then we'll start feeding. If the infant has significant ultrasound markers with or without perforation, we'll keep MPO for a longer period of time until we have the lab work clinically and ultrasound normalized, and then we'll start feeding. Before we started our integrated approach, we had higher than national average cases of neck at St. Boniface Hospital, and we started our program in 2016, and after that the trend has been going down, and now it is below the national average. The same for Health Science Center. We were higher than the national average. Our center in blue bars, national average in yellow bars. And after we started our program, now we have very low rate of neck at HSC Winnipeg. Now we have 4 main conclusions. First, gut injury is multi-trigger disease with variable pathophysiologic mechanisms. Although abdominal X-ray is helpful with perforation, but it is limited in assessment of the degree of gut injury. Ultrasound is superior to abdominal X-ray in identifying prognostic value and the complication. We have to keep in mind that ultrasound is operator dependent. The same like any ultrasound modality, intestinal ultrasound needs a lot of training and experience under supervision. In this presentation, we focused mainly on intestinal ultrasound assessment of neck and the gut injury, acute gut injury, but ultrasound can be also used in surgical cases, including assessment of volvulus, malrotation, adhesion and strictures, and also intussusception. But all of these indications need to be discussed in a different presentation.
Hi, Jasser.
Welcome, Daniel. Can you see me?
Yeah, perfect. Well, first of all, thank you so much for joining us tonight. We really appreciate all the work you've done. We follow all your papers, and you've been a huge influence, and we really appreciate all the efforts you've done to share all your knowledge in low and middle income countries, and the disposition to introduce ultrasound and other tools for monitoring our babies. So thank you so much.
Yeah, thank you very much for the kind invitation and joining your wonderful group. I can see really a very big number of attendees, which is really amazing. And I'm with you tonight. Whatever question you have, feel free to ask.
Perfect. So we're going to start with some questions from the audience. In the setting of ascites or peritoneal fluid, and when you have a lot of ascites and you have also perforation, how often is to see air bubbles or some kind of artifact that would indicate us that although we have a lot of fluid, there's also perforation going on?
Yeah, thank you very much. That's a very good question, good technical question. I have to mention that you have 4 main red flags for surgery assessment. When you have one of these red flags, probably you need to consider surgical intervention if you haven't done that yet. The 4 red flags: number 1, when you have complex peritoneal fluids, it means that you have significant gut injury with the fluids and septation. So don't hesitate to consult surgery if you haven't done that yet, regardless if there is perforation or not. For perforation, there's 2 types of perforation. The first common type, which is free air, and when you have a free air, it might be really difficult to assess. You have too much free air to assess by ultrasound. That's why integration of X-ray when you have free air is important, especially the cubitus position. But sometimes, especially in challenging cases, you may have air encysted. Especially when you have too much fluid, you may have air encysted surrounded by intestinal loops or surrounded by fluid. In this situation, ultrasound is more helpful. So you will see the air encysted in the middle, surrounded by loops or surrounded by tissues, and the air is fixed. When you have air is free, should be moving when you apply pressure by the probe. But when you see air with A lines in one position and does not really move away when you apply pressure, then it is concerning of encysted air. And encysted air, you may miss it by X-ray. X-ray only for free air. When you have air moving without any limitation and free, detected by X-ray. Encysted air, you will not see it easily by X-ray. Encysted air, you may actually interpret it by X-ray as just one loop with air. But ultrasound can detect that easy with more experience. So another red flag for surgical, by the way, for surgical intervention is global thickening of the bowel. If you have thickening of the bowel all over the abdomen, you have significant bowel edema, and that's concerning to consult surgery. Or you have global thinning of the bowel. Global means all over all quadrants. Thinning of the bowel, that's also concerning. The fourth important red flag, when you cannot see any color Doppler, and all over the bowel, there is ischemia. So apply 2x2 color box with low scale and the high gain, and you cannot detect any perfusion. This is very bad sign, and that's concerning of significant vasoconstriction of the bowel. In this situation, we use dobutamine low dose between 5 to 10 mics to improve the gut perfusion, because that's almost typical like vasoconstrictor physiology for shock, but that's localized for the abdomen, localized for bowel. When you see too much hyperemia and a lot of blood supply or significant hyperemia, circles or Y-shaped, this is more another phenotype of gut ischemia, because hyperemia doesn't mean that the gut is getting a good blood flow. It means that the blood is stagnant in the big blood vessels and there is no blood flow going to the tissues periphery. So in this situation, we use vasopressors like norepinephrine to increase the perfusion, or vasopressin, although some people may consider vasopressin as gut may worsen gut ischemia, but vasopressin in case of gut shock, and when you have this phenotype, it will improve. If you're worried about vasopressin side effects, you can use norepinephrine or epinephrine. I will let you maybe translate first instead of just talking too much.
Perfect. No, I think what we might do is when we upload the talk in our channel, we will try to put subtitles on.
Okay.
Another question would be, normally the people that are doing different sort of echoes have some training in TN echo, and we use a lot the celiac trunk and the superior mesenteric. So we normally there's the idea that it might help somehow, but we read the paper by Deepak Lewis where it doesn't help to predict feeding intolerance or necrotizing enterocolitis. But does it have does it help as a marker, the Doppler of the celiac trunk or the SMA?
Not really, to be honest, because you have a lot of factors that might play a role. So, for example, if you have PDA, you may have some technical issues when you have too much air or so. You may not get able to get a good Doppler. But whatever, even if you have absent Doppler because of ductus, or you may have low diastolic flow Doppler that might also reflect overall shock or low blood pressure, but does not really reflect typically a specific gut injury. I'm using a superior mesenteric artery sometimes together with a superior mesenteric vein position to rule out volvulus or malrotation.
Okay.
When you have the superior mesenteric vein surrounding the superior mesenteric artery and making wire pull sign, that could be concerning of malrotation. That's probably in gut assessment the most helpful sign of using superior mesenteric artery. But like to rely on Doppler, that might be useful to detect the impact of PDA, although I don't think that's very reliable to decide if the gut getting hypoperfused or not based on only reverse diastolic flow. Near field spectroscopy might help more than the superior mesenteric artery blood flow.
Perfect. Thank you so much. Dr. Carlos Aldana is asking, he has a 29-weeker preemie 10 days old with abdominal distension during the weekend. Then the baby clinically improved, and after a brief period of MPO, when he restarted the feeding, the abdomen was with normal exploration, nice and soft. He did an ultrasound and he found a lot of gas in portal vein branches, and the baby clinically looks good. So how often is because we can see mild portal gas, and sometimes it might be related to the IV infusion even, right? So yeah. How would you interpret that when you have sort of a mild to moderate portal gas and no other sign.
Yeah, that's a wonderful question. Very good question. And let me explain that in more details. Because typically in the presentation, we could not explain everything in details and all of the differential diagnosis. You need probably a course, a detailed course with many presentations about everything. And soon on New Beads Academy, I'm just developing a course now, detailed course on all of the management aspects and ultrasound related to abdominal point of care ultrasound in general, surgical cases, not only bowel assessment, assessment of hypertrophic pyloric stenosis, reflux, surgical cases, microcolon, like almost everything that you need to know about as abdominal point of care ultrasound. And one of the aspects that might be associated with portal venous gas, three things. One of them, it could be related to a catheter being in. And when you see the air in the liver, usually in the distribution of the hepatic veins, not portal vein. Because now you have the flow from the catheter, usually it is following the hepatic vein if you have central line. But if you have a umbilical venous line, which I assume the baby might be old for umbilical line, you will see it also in the portal vein. So if you see air in the portal vein and there is a umbilical venous catheter, that might be related to that catheter. If you don't have catheter and the infant is actually clinically well, we have seen portal venous gas in a cow milk protein allergy. When you introduce additives to the milk and even with the breast milk, if the mother consuming dairy products, you may see also infant with the cow milk allergy, and it can be early. Usually NIC happening late, happening on the after beyond the third week of life. Does not happen early. What happened early could be perforation, spontaneous perforation. If you give, especially if you give medication that induce perforation, or cow milk allergy, or maldigestion. You may have insisted milk inspissated milk syndrome. That might give you the similar picture with the distended abdomen, vomiting, the same we have in cow milk allergy. And as I explained in one of the slides, if you have eosinophilia, leukocytosis, thrombocytosis, and low CRP, together with either localized pneumatosis or portal venous gas very mild, that could be cow milk protein allergy, not really NIC. And what you need to do in this case is just give a hydrolyzed formula rather than other formula. Even if the infant was breast milk, you just give a few days on hydrolyzed formula and resume breast milk gradually after that.
Perfect. Thank you so much. When you do hemodynamic assessment of these babies, thinking about like classic necrotizing enterocolitis, I've often found that normally you have a hyperdynamic circulation, like kind of picture. But is there any specific like hemodynamic pattern you've recognized, and sometimes to see if it's PDA related? They are also asking that.
Yeah, definitely. So PDA, although not very common, it might be contributing either PDA or the treatment for PDA. Or if we have seen when you transfuse Baghdad disease on top of PDA, so you have double hit, two things at the same time. That might I have seen, but not very few cases. Maybe in 10 years, maybe a couple of cases. So that might be associated with PDA, and that has been like already described, although not very common now. But in case of hemodynamics, the impact of NIC itself on hemodynamics, if that's the other part of your question, just to ask as a question from the other side. When you have infant with NIC, typically might be presented with shock. And the infant might be presented with shock, and you may treat the shock, and you may not really diagnose the case as NIC. That's why in any case of shock, any case presented with shock, we have to assess the abdomen as part of the crashing protocol, and this antibiotic for hidden neck. And we have seen a lot of cases. The typical presentation was hypotensive shock. We treated with antibiotics, although the culture was negative. And then when we assessed the abdomen, we found that the issue is mainly related to neck. And the opposite might happen. You may have infant with significant neck and complicated with shock. In this situation, you have to treat the shock. If there is hypotensive shock, you need to use vasopressor in most of the situation. But in some situation, you may have normal blood pressure, although you have severe gut injury. And again, there's two phenotypes that I would recommend low dose of medication, cardiovascular medication, to support gut perfusion. It is based on the physiology. There is not a lot of evidence to support this theory, but there is two main phenotypes of compromised blood flow gut injury. The vasoconstrictor phenotype, when you have severe ischemia, when you apply color Doppler, you cannot see any blood flow, especially if it is global. I use dobutamine, like 5 to 10 mics, and then I have seen few cases responded without need for surgery. And when you have severe hyperemia in the abdomen, although the blood pressure borderline or not very low, I use just low dose of vasopressor, either norepinephrine or epinephrine, that might improve this local vasodilatory effect and improve the perfusion of the gut, like just to prevent progression into significant gut injury or gangrenous bowel.
Thank you. Regarding some technical aspects, what would be the minimal acceptable specification for the probe?
Yeah.
If you have, they are asking if you have a 15. I think that's pretty good. But what would be the minimal requirement?
So to assess the liver, so there's two parts. We assess the liver by microconvex probe, which can range between 8 to 14 or 8 to 12. That should be fine. Because you assess the liver is a big organ and you assess the deeper part of the liver. That should be fine. But the intestine is superficial organ and you need linear high frequency probe. So use the highest frequencies that you have. If you have 20, use 20, which what we are using. If you don't have to use 20, just use the highest that you have, either 12, 14, 16. You just use the highest the highest frequency by linear probe. You can still use a microconvex probe to assess the abdomen. If you don't have linear probe, that should be fine. But the idea is use the highest frequency you have. But if you have low frequency, less than 10, that's probably will be very difficult to view the bowel with good quality of images, especially in premature babies. So at least you have something in teens as a frequency. I mentioned, by the way, another technical trick. When you put the probe over the abdomen, the linear probe, you'll see sometimes just the air lines. And to get rid of that, you need to apply pressure. So the key of success to get a good image, to apply pressure. And you cannot, in most of the cases, get a good image without applying pressure. And the pressure can be variable, can be a little bit painful pressure, or can be reasonable pressure based on the amount of air in the abdomen. And if you see too much air, then you can change the position. So the air will move up and you do the other part of the abdomen by probe. So get the air moved away from the area by just use the value of the air moving against the gravity. So put the right side up and evaluate the left side. Or another idea, keep the infant in prone position for half an hour before the scan, so the air will be moved to the back, and then turn the baby over and assess the abdomen from front. That's another trick, trying to get the air away from under the probe.
Perfect. You just answered another question that they did. And when you have meconial disease like meconium plugs, how often is to have what other markers do you take into account? Is it frequent to have a lot of distension and the problem is just the meconium plug? What's your experience there?
Yeah, the meconium plug is not very difficult to assess for one reason, because usually it happens early, like first day of life or first few days, when there is no much air yet. So clinically presented with vomiting, distension, and usually meconium plug will be differential diagnosis of Herschel-Blank disease. So you will see the colon dilated with hypoechoic. The meconium is hypoechoic, because still not yet mixed with air. So you'll see it as very clear hypoechoic material filling the colon without good peristalsis. And you will see the walls very healthy with the signature very clear and well perfused bowel. Your differential diagnosis now when you assess for meconium aspiration, is it obstruction with compression of the blood vessels like volvulus or malrotation? So this is your main concern, because you need to decide, is it surgical emergency or not? So you can easily rule out malrotation easily as infant, as someone who's expert and now is able to assess for surgical cases. So you will see the signs, as I mentioned, for malrotation, which is different presentation. You need a different separate presentation to talk about the surgical cases. So you will see the wire pull sign, circles of color in the mid-abdomen concerning of malrotation. And the infant should be with lactic acidosis and sick with abdominal distension, like clinically sick, which is different from meconium aspiration, just vomiting with distension. And you will see the gut perfusion, very good perfusion, without any other typical signs for malrotation. To typically differentiate from Hirsch's bronchial disease, you may see that's an expert person, there's the terminal part of the colon, the sigmoid colon collapsed. And you see the distal part of the colon very dilated with meconium. Again, that needs a lot of experience, but the most important as a clinician or as a point of care to reassure the surgical team and your team that the perfusion is good, there is not an urgent case, and the gold standard test to differentiate meconium aspiration from Hirsch's bronch is a biopsy. If the infant did not respond to irrigation of the rectum and still did not pass meconium, we may get barium or contrast, which actually might help with the osmolality of the contrast to get the meconium plug improved, if not improved with irrigation. And then if you're still in doubt about Hirsch's bronch could not be ruled out, you need a biopsy.
Perfect. Thank you so much. And just to finish this section, we appreciate your participation, and we will be surely promoting all the workshops and the courses you do, because it has raised a lot of interest here.
Yeah, my pleasure. And actually, you may wait until we may convert actually the online course translated into Spanish.
Yeah.
We
saw that.
So I will let you know, and then you probably can let your team wait until we get the course converted into Spanish, and we'll try just to offer it for a low price. We just try to maintain the website expenses, where that's not really business for us, but just to try, because it's very very expensive platform to keep it running. But we'll try to minimize the registration fee, especially for middle income countries.
Yeah, we really appreciate. And just to finalize this amazing session, can you explain us how you integrate ultrasound and NIRS? Like, how do you, because I've seen here in our country a lot of times when they are looking for a neck baby and they have NIRS, they normally do cerebral and renal. But can you explain how you use the ultrasound to find the areas where it's suitable to put the NIRS, the abdominal NIRS?
Yeah, that's a very good question. So when you use near-field spectroscopy for the brain assessment, you can leave it. You can leave it even for 1 week, as long as you have a question or you have indication for NIRS for assessing the brain. We are not routinely investigate or monitor everyone for NIRS. We monitor for 5 main indications for premature for the first 3 days of life, during transition, very premature, like less than 27 weeks, for hemodynamic stability, for HIE, for hydrocephalus, for infant with severe hypoxemia or hemodynamic stability. For the abdomen, if you suspect neck, it's better to integrate it with ultrasound, because the limitation you have in the abdomen, you have poops, you have air, you may have fluid, peritoneal fluid, And if you put the probe on, you are not sure what the signal that you are detecting. And the new smart machines, without mentioning any brand, they are very good to differentiate signals from real tissues or not. But that's not 100% sensitive. So if you put the probe on and you are sure that you have underneath bowel tissues, not any other organ like liver, enlarged liver, or poops or air, then apply the NIRS, and that's just for spot check for a few minutes to get a baseline number and compare it to the brain. But if you leave the probe on, sensor on for a long time, you'll get a lot of artifacts, numbers from not really from the tissues. And you need to apply a little bit pressure, the same as we do with ultrasound. You apply a little bit pressure, you put the probe on and apply a little bit gentle pressure over the abdomen until you get a stable baseline number for probably 3 to 5 minutes. And then once you detect that area, which is really typical bowel tissues, you can ask the bedside nurse make a mark, and they ask the bedside nurse to put the sensor on every 2 to 4 hours, and I get the same value, and you can monitor the trend. But I don't advise to keep the probe on for a long time because that will give you a lot of misleading numbers. And you can evaluate the right abdomen. You have to be sure that you are below the liver, or left abdomen. Also, you be sure that you are over the intestinal loops, not other collection of fluid or so. So that's anterior part of the abdomen. Just cross the umbilicus. Be sure that it is below the liver and or in the left side.
Perfect. Well, thank you so much. It has been really a great session for us, and we will be in touch. And just again to say thank you for all your work and for all the impact you have with all the educational resources you've done here in Latin America.
My pleasure. Yeah, at any time. And we hope to also conduct any whatever session that might be extension of this session in the future regarding the surgical cases or other applications of abdominal POCUS with my pleasure, and good luck on your wonderful work that you have been doing in Mexico and the Latino American, and also the entire America. Like you're well known everywhere.
Thank you so much, Yasser.
My pleasure.
Bye. Good night. Thank
Bye,
you.
everyone. Thank you.
Thank you, everyone.